Nath, Deputy Manager, Marketing Trans-Asia, to give a valuable insight on this topic, newest parameters in hematology. Over to you, ma'am.
Thank you, ma'am, for the introduction. A very good morning to respected doctors and distinguished guests. Firstly, on behalf of Trans-Asia Biomedicals, I would like to express my sincere gratitude to the organizing committee of Pathcon and Dr. Jyotsna ma'am, HOD Pathology GMC, for giving us this opportunity to give a small presentation on newer parameters and automation in ESR. Before I begin, a small overview on Trans-Asia. Launched in 1979, we are now in the 47th year of serving the IVD, and we are catering to almost all the segments, basically for hematology, clinical chemistry, immunology, critical care, blood bank, urinalysis, coagulation, and diabetes. Our reach is immense across the globe. We have approximately 90,000 plus of installations with practically approximately at least 150 plus tests done every second on any Trans-Asia product. A strong field force of 900 plus, total 1500 plus employees, and 26 zonal offices and 500 plus channel partners. So we have approximately 50,000 plus labs equipped with some or the other Trans-Asia product, 12 international subsidiaries, and we are present in around 100 plus countries. These are our research and development centers in India, France, Czech Republic, Austria, manufacturing facilities in Daman, Baddi, Mumbai, Seeps, Sikkim, Vizag, Czech Republic. Recently taken over manufacturing facility, it's the largest in Asia at Andhra Pradesh Medical Tech Zone. Over here, it's the first of its kind where we have approximately 30,000 plus square feet, and we claim at least 2 million rapid tests per month. That is the possibility of manufacturing out here. It's a 4-acre facility, where we are integrating all the functions of manufacturing, R&D and supply chain to deliver the state-of-the-art diagnostic instruments and test kits. And Trans-Asia always believe in giving back to the fraternity, so we have this URBA Global Institute of Medical Technology, again in AMTZ, Visakhapatnam, and we are partnered with about 150 medical device manufacturing units. We have courses here for AI, robotics, digital imaging and so on, so it's a world-class infrastructure. Taking over to the new products, the new parameters in hematology. As we all have seen the evolution of hematology analyzers from the basic CBC or the total count, the indices, moving over to special advanced clinical parameters. So it's a dynamic clinical decision tool which is now available to the pathologist, which can be forwarded to the clinicians as well. A faster detection of disease before the traditional parameters can make a change. We are able to track the disease progression faster. Also, it's a non-invasive, real-time bone marrow insight at practically no additional cost. So this only helps in improving the clinical confidence and foster better patient care. Moving forward to the parameters, newer parameters in the RBC lineage. Reticulocytes, as we all know, are immature precursor forms of the RBCs. The retic panel constitutes of not just the retic count. We have additional parameters like the RET-HE or the hemoglobin equivalent in reticulocytes, immature reticulocyte fraction, reticulocyte production index, mean reticulocyte volume, the stages of reticulocyte maturation as we see it in the Hellmeyer classifications. These provide a real-time insights as to response to the anemia disease, the correction, progression, the bone marrow failure syndromes, the hemolytic disorders. RET-HE gives us a real-time iron availability for the RBC production. A good differentiating marker between iron deficiency anemia and anemia of chronic disorders. So unlike ferritin and TSAT, this is not affected by the inflammatory conditions. It gives us a functional iron availability for erythropoiesis. Eliminates unnecessary iron therapy or transfusions, and a quick assessment of treatment effectiveness. We have lot number of abstracts available, and this is a very renowned one way back in 2005. Canals et al. Had given a good distinguishment of how RET-HE with somewhere around lesser than 25 picograms when it is seen. It is more indicative of an iron deficiency in comparison, discriminates it from the anemia of chronic disorder. Majority of the laboratories have seen the rect HE as a normal range somewhere around 28 to 32 picograms. Of course, this can vary a little based on lab to lab and the demographics available. But a classical case is where they have given us a distinguishment between the rect HE and can help us in differentiating for IDA and anemia of chronic disorders. A number of other parameters like you would like to have for anemia classification on the microcytic population, the macrocytic population. A simple tool like Menzer index and RDWI, which is very, very effective and quicker to differentiate between your iron deficiency and beta thal. Immature reticulocyte fraction gives us a real-time information on the quality of erythropoiesis for blood transfusion assessment. Like, for instance, if we have a high IRF and a low hemoglobin, this indicates that the marrow definitely is responding, but there's also an underlying hemolysis or a blood loss happening. A low IRF and a low hemoglobin is definitely shows us towards a marrow suppression, so leads us towards in this direction. The percentage of hyperchromic cells, these are also again useful in anemia classification. Mean reticulocyte volume, that is the average size of reticulocytes in the blood. It gives you an assessment of the bone marrow activity and the overall erythropoiesis. Generally, higher MRB is seen in macrocytic anemias or megaloblastic anemias, and the lower MRBs generally are showing an indication of iron deficiency or anemia of chronic disorders. Reticulocyte production index is another tool which helps the clinicians to evaluate the bone marrow's response to anemia. It's observed that RPI beyond 2, greater than 2, shows an adequate response. Presence of fragmented cells can also be computed and informed, and that suggests on a red cell injuries. As we have seen in the parameters which are available in the RBC, which is a very good tool, like for IRF, is a parameter which can tell you much in advance before even the hemoglobin can change what's happening at the marrow level. Similarly, we have IPF, which gives us a thrombopoietic activity happening at the marrow. So over here, we are able to distinguish what is the cause for thrombocytopenia. Is it related to destruction or hyperproduction? So out here, like we have both platelet and IPF low. It's a clear tool that's an indication of a marrow production issue. Whereas suppose we have an IPF high but a platelet dropping down, this is possibly a case of destruction happening parallelly in cases of autoimmune disorders or dengue as it's commonly observed. Clinical applications of IPF also helpful as an early marker for platelet recovery in post-stem cell transplants, chemotherapy, dengue, and it eliminates unnecessary transfusions. Immature granulocytes also we are aware of its importance, especially in understanding the bone marrow activation in response to infection, inflammation, sepsis screening and monitoring, and moreover this is available in the routine CBC at no extra cost. Post-surgical infection monitoring. Apart from these, there are many more additional markers, like we have inflammation parameters like NLR or neutrophil lymphocyte ratio. This had come into a very big limelight during COVID, a very good marker in several malignancies. Lymphocyte monocyte ratio, a marker of systemic inflammation, generally observed in certain solid tumors of lung cancer, gastric cancer, etc. Platelet lymphocyte ratio, inflammation marker in cardiovascular diseases and autoimmune. Cutoff of more than 200 is basically seen in such cases. Now these markers are already in use, they are there, but there's not much of substantial work done. So that is where we feel that having an instrument of this kind placed at any installation would definitely help if it is also accompanied with good amount of scientific publications which can be even put in the international journals and also in as a case study, so that everybody gets advantage of these special parameters. It will help in the betterment of patient care. Some more to it, like for viral infections, you have the HFC count or the 5-fluorescent count. Immature eosinophil expression is a very rare parameter and very rarely found in eosinophilic leukemia. But again, this is possible and it's a way computable. The instrument what we're talking about in the specialized parameter basically has an AI cube technology. Now this is something which is very recent and new, because here we're able to capture the cases of AML and ALL. The instrument is provided with lots of data and information on the parameters and the graphics, based on which it is able to distinguish and give a good insight. So based on the data, and this was a classical case of a female of 36-year-old was admitted, and the diagnosis was very high, WBC was sufficient number of blasts and immature grans, And the suspect and the flagging was leukocytosis, neutrophilia, shift to the left, and it also correlated with the smear microscopy based on the number of promyelocytes. You can see 21%. The final diagnosis was AML. So this was picked by the analyzer. Similarly, another case of ALL, the male 14-year-old, a very high count of WBCs followed by monocytes and a high count of the screening given by the system was basically on leukocytosis, okay, lymphocytosis, mononucleosis, and which again correlated with the smear, and the diagnosis in this case was acute lymphoblastic leukemia. So the whole idea would like to convey is that when we have so much of parameters available, a request to all is to ensure that a lot of justice is done and we do not downgrade these systems to a basic 5-part and use all which is available on the system. The technology behind these is the laser-based fluorescent flow cytometry using a special fluorescent dye, especially for the differentials and the reticulocytes. So based on the granular content, the cytoplasmic content, the nucleic acid content, you're able to get a good differentiation, and the graphics are plotted in this manner for the differentials, and this is for the retics. So in the retic panel, apart from the red parameters, what you have seen and the newer RBC indices, it also gives us a clue on the optical platelets. Platelets, as we know, is a biggest challenge in the laboratories, especially when you have interferences from microcytes or schistocytes coming and giving you a pseudo count. So in such cases, because instrument just is been programmed by size, there's no way you can differentiate and the way we screen on the microscope. But in this optical method, it is done based on the RNA content. So the separation and the accuracy is much more better out here. Immature platelet fraction, as we already seen, it's a very good tool for distinguishment and checking out what's happening at the marrow level as far as platelets are concerned. So all this information is available. This is how the system looks like S7100. I'm proud to announce that this is there in the GMC hospital, and you can see it's a very compact model. We have RBC and platelets reported both by impedance and optical. Total parameters are 71, throughput up to 100 tests per hour. Apart from the different tests mode, like for going in for the differentials or the reticulocytes, there's an additional leukopenic and a low platelet mode. Sample volume is really low, lowest in these kind of instruments, basically just 30 microliters. Total number of reagents inclusive of the cleanser are just 7. A very high linearity of WBCs around 5 lakhs, platelets around 50 lakhs, and again inbuilt with the AI Cube technology. We have done many studies and validations, and particularly launched in just a year back, and with the best of the class in the industry. So, and the papers were published at the Hinduja Hospital, Mumbai, with BLK Max. There's a paper abstract which was submitted in the International Society of Laboratory and Hematology, France, on the newer parameters, and also we had done it at Apollo Hospital, Chennai. So a lot of validations and papers are already existing, and we also request all the laboratories and the good esteemed institutions to support us and to work on these clinical case further on this. With this, I come to an end for this particular topic. I'll just take you through a smaller topic on the ESR automation. Take a break now.
Postgraduate department, so I would like to add one thing for first year students especially, that these are the advances and these are adding to our field every day almost. But I would like to make a thing to come to your notice, that counts and morphology in case of hematology is the basics. So master that first, and then of course the technology is there. Thank you. And I would like to thank ma'am to giving this opportunity. And I would like okay.